Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Pathak, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. Sexual health is a topic that's often overlooked in healthcare visits, not because there's nothing to say about it, but often there's discomfort, sometimes on the side of the patient and sometimes on the side of the healthcare provider. Today, we're changing that. We're having a discussion about erectile dysfunction, a condition that affects roughly half of men in their 50s, with that number increasing every decade. So that means for many men, this is the norm, not the exception. But erectile dysfunction is still not being discussed. Another reason it's so important to discuss changes in sexual health and wellness is that erectile dysfunction is very often a sign that something else may be going on with your heart, blood sugar, or blood pressure. In this episode, we're going to take a step-by-step approach to what is actually happening in the body when erectile dysfunction occurs, what lifestyle factors have an impact on it, and the treatment options available. We'll also discuss the psychological effects of this experience and how people in intimate partnerships can navigate this together. Whether this is something you're personally dealing with or someone you love, this conversation is one you won't want to miss. First, let me introduce my guest, Dr. Ashley Winter. Dr. Winter is a board-certified urologist, fellowship-trained in sexual medicine, with extensive experience treating sexual health concerns across all genders. She's dedicated to providing comprehensive care for both men and women with sexual dysfunction, offering individualized treatment plans to improve sexual health and overall quality of life. Welcome to the WebMD Health Discovered podcast, Dr. Winter.
Thank you so much for having me. I'm very happy to be here.
Well, we're very happy to have you. And before we dig into our topic for today, I'd love to ask about your own health discovery, whether it's in your research or your work with patients. What led you to this interest and to really figuring out ways to improve people's health through sexual medicine?
Yeah, well, as me and some of my colleagues always love to say, sexual health is health. When you're going through treating, everybody always wants to save lives, but there's a part of being a physician that also is about quality of life. And I think sexual medicine, yes, absolutely, we can save lives. There's a very high correlation between erectile dysfunction and cardiovascular disease, right? We could actually save lives by talking about erectile dysfunction, but we also, as clinicians, have the opportunity to care deeply about people and their quality of life and make sure that they're having love, having intimacy, and doing these things that are so fundamental to us as humans. And I really love the opportunity to dive into that. I think there is so much focus on prolonging life and in our culture as doctors, and I love the opportunity to really flip that a little bit.
I love what you're saying because I think as we are thinking about what matters in medicine, we're recognizing that connection and that sense of love and connection is so critical to long term health and the health span. So let's take a bit of a step back and just explain what erectile dysfunction actually is and how does it manifest?
Really, the definition of erectile dysfunction is that you're not able to get or maintain an erection that is sufficient enough for penetration or sexual activity in the way that you're preferring to do it, right? That's kind of a simple understanding. On a biologic level, to really understand what erectile dysfunction is, we have to understand what an erection is, right? So an erection is when there are signals sent to your penis from the brain, whether it's from touch, whether it's from erotic thoughts. There are signals sent from the brain to the penis, and that releases a compound called nitric oxide, and that causes chambers of the penis, the erectile chambers of the penis, to dilate. And that allows more blood to flow into them, and it causes the penis basically to become hard. So it's a combination of not just more blood flowing into the penis, but it's combination of the heart pumping, the brain telling the penis how to act, and these erection chambers in the penis really relaxing and dilating. Now, when you have difficulty getting or maintaining that erection, it can be from a number of different causes. I'd say our two major baskets that we think of is psychological versus non-psychological, right? So psychological would be something like you think performance anxiety. And that's because your brain is in fight or flight mode, right? For whatever reason. From an evolutionary standpoint, you don't want to have an erection when you're trying to run away from a predator, right? That doesn't work. So when your body is under stress, you don't want to have an erection. You want all the blood flow to go to your legs so you can run away from the predator. And that can manifest in modern society, right? As I'm nervous about sex, I'm stressed out at work, and so my head's not in the game. And when that happens, no matter how healthy the penis tissue is itself, the brain is not sending those nitric oxide signals to the penis, and you're not getting or maintaining the erection. So that's kind of that category. And then the second category is what we think of the more physical side. And that's this whole host of conditions that could lead to not getting or maintaining that erection. What are some major examples? As I talked about before, diabetes, right? We know that diabetes causes injury to your peripheral nerves, and you need the nerves to connect the brain signals to the penis. If those signals are not traveling to the penis, then it's not going to respond. Conversely, if you don't have healthy nerves to have sensation in the penis, it's not going to respond, right? So if you're feeling numbness and tingling the same way people with diabetes feel numbness and tingling in their fingers and their toes, they can have numbness of the genitals, right? In both men and women, I would point out as well. And so if you're not feeling that or the signals are not conversely going back out the way they need to, then you're not getting or maintaining the erection. Now, on top of that, cardiovascular disease is a big component here. When you have less blood flow to the penis, not just during erection, but during normal rest, we have very small blood vessels to the penis. They are one of the first sets of blood vessels to be affected by buildup of plaque, right? We always think of the plaques in your heart, but you can have plaque in the arteries that go to the penis. And when that happens, you have chronic decrease in blood flow to the penis. And that can cause scarring to the tissue of the penis. And then those nice chambers that are supposed to expand and fill with blood don't expand and fill with blood. So that is kind of a very broad overview of how we define it and some of the causes that could lead to it. I should also mention hormonal factors have a big role as well. If you have very low levels of testosterone, certainly both the nervous system is not able to send the correct signals. You're also going to have lower libido and interest in sex, amongst other things.
So, help us understand how common erectile dysfunction is and at what point in life is it most common? When do men typically start to experience it?
I don't know the actual data on the psychogenic ED, but I tend to say that we see that more in younger adults, right? And then when we're thinking of the non-psychological ED, it definitely goes up in rate as you get older. The general thinking is it's about 50% of men in their 50s, 60% of men in their 60s, 70% in their 70s, and so on and so forth. So actually, once you get to a certain age, it is the norm and not the exception. And we have so many tools to treat it. And moreover, your physician has so many tools to use this as an insight to your overall health that I hope people don't feel isolated. And I would also point out, right, there are companies that have basically gone public over selling erectile dysfunction medication on the internet. So if it wasn't a common problem, those companies wouldn't be worth billions and billions of dollars. So the point being, all those other people are out there getting help. Please, please, please talk to somebody you trust about it. And I will do my part also to keep talking to my fellow doctors about not being weird about it. And if a patient brings it up, because it's not a big deal. This is part of health.
So let's go through a step by step approach. You've brought it up in the office. Help us understand sort of your process in thinking through what could be going on and what tools are you going to use to identify what is going on in this individual patient that's going to kind of lead you down the path to finding the optimal treatment for this person.
We take a history, we do a physical with a history, or finding out how long it's been going on for, how bad is it, have you tried any medications for it in the past. I love asking about morning erections or nocturnal erections, right? Because that can be a good indicator whether or not there's a psychological component, right? Because traditionally, if somebody has performance anxiety, they're going to still wake up with an erection in the morning. Whereas if somebody has a severe physical component to the erectile dysfunction, they've either lost or mostly lost those morning erections. So that's a great thing to ask about. Of course, we're looking for, their medication history, right? There are certain medications that can contribute to erectile dysfunction, such as beta blockers. There are lifestyle factors that are very impactful on erectile dysfunction, right? Like tobacco use, cigarette smoking is probably the number one modifiable lifestyle factor that is really damaging to the penis. So we're going to be asking about that. We're going to obviously be asking about things like sleep. We know having sleep apnea, for example, is not good for your penis. So we're asking, just overall big view of health. I personally, since I'm not in a primary care environment, I'm not checking people's blood pressure when they come in the office, but that's something important to have checked because, of course, again, blood pressure can damage those very delicate blood vessels that go to your penis and lead to those nice erections. So we're looking at that. And when I do an exam, I'm just looking for signs of low testosterone. Do they have small, soft testicles? Do they have scar tissue in the penis? That's something called Peyronie's disease. And when I look at labs, then we're looking at really the whole picture, right? So have they had a testosterone level checked? Have they had a lipid panel, right? I've seen people that have gone to a cardiologist and were told, hey, your cholesterol is borderline. You don't need to worry about it. You don't have symptoms. And I'm like, aha, the erectile dysfunction is a symptom of potentially this high cholesterol. And this is actually very commonly the first symptom. So you should go back and talk to your cardiologist about modifying your cholesterol level. And then we're looking again at the A1C. Does somebody need to be screened for diabetes? And those, I'd say in broad strokes, are the initial assessment.
Can you talk to us a little bit about treatment options? So, if we are really thinking that there's a chronic condition like diabetes or high cholesterol or high blood pressure that needs to be managed, that clearly fundamentally needs to be managed as the foundation of the treatment. Then also lifestyle factors. So, really addressing smoking, addressing things like sleep and stress. Is there a role for nutrition, for physical activity in that baseline prescription as well that you're thinking about?
That's a great question. I mean, everything that improves your cardiovascular fitness is potentially going to improve the erections, right? If you have very profound scarring of the penile tissue, then maybe it's not going to help. But people always ask, like, can I reverse my erectile dysfunction? And on some level, there is data that if you're taking, let's say, a low dose of continual tadalafil, right? Then that's a PDE5 inhibitor. So people think of like the most common erectile dysfunction. And if you're taking a low dose of that continuously, it may actually help maintain penile health by improving blood flow. But that said, when people are like, hey, doc, can I reverse this? I'm like, everything you can do to make your blood vessels healthier is going to set you up the best to potentially have a healthier penis that's working better on its own. And most of the drugs we're giving you are not, they're a temporary fix. They're going to help you get that erection perform, but they're not restore your penis back to the penis you had when you were 21, which is what you want. We all know that's what you want. And because of that, yes, absolutely. If you can drink less alcohol, stop smoking, exercise, particularly cardiovascular exercise, all of these things are good for your penis.
So then let's spend a little time talking about some of the symptomatic treatments that patients often ask for, whether that's pills, injections, devices, even surgery. Can you talk to us a little bit about what's in your toolbox there?
Absolutely. The mainstay of therapy that has level one evidence, that's the best study, are the PDE5 inhibitors. And I love using them. They used to be extremely expensive. Now they are very inexpensive. Even if your insurance doesn't cover it, you can get it, with GoodRx. You can get it with the Mark Cuban pharmacy. They're generic. You can get, half a year of them for like $10, basically. And they're great. And I was actually presenting at this internal medicine conference this last week. And one of the things I highlighted in talking about sex friendly general urology was just that there's observational studies, not clinical trials. So it doesn't improve causation, but there's clinical There's observational studies showing that these category of drugs, PD5 inhibitors, reduce something called MACE, which is like major adverse cardiovascular events, right? So on an observational level, those drugs, for some reason, seem to actually have beneficial cardiovascular health outcomes. So I'm just a huge fan of I'm a huge fan of these medications. And oftentimes the patients have actually already tried it. But if they haven't, obviously we're going to think about giving them that. A really easy one is just doing a low dose of tadalafil every day. That's very long acting. They don't have to worry about like taking it before sex or have it interfering with their spontaneity. And because this often happens in men who are getting older, that is also an FDA approved treatment for BPH symptoms. So, difficulty like emptying the bladder. So it's kind of like a, double whammy. And they're very happy to take it. So that is my go-to starting place. There's also devices, that pump the blood into the penis. I find patients have a little less comfort with those, but there are tons of options on the market. Just maybe ask your urologist which companies they recommend, because there are products out there that are really high quality and products that are not. So talk to somebody you trust. There are online stores even by your board certified urologist where they sell penile erection devices or constriction bands. So that's another area. I would also, as a side, and I didn't talk about this, when we think of these PD5 inhibitors, again, tadalafil, sildenafil, you're thinking the little blue pill, people often fear those because they think it's going to give them a spontaneous erection. That is not true. What those medications do, they amplify the signal that the brain is sending to the penis. Meaning, if you are not sending the sexy signals from the brain to the penis, stimulating the penis, if you're not interested in sex, it's not going to generate an erection. It is amplifying that nitric oxide that we talked about before. It's amplifying that. If that signal is not coming to the penis in the first place, it's not doing anything. I just tell people you're not going to be doing your income taxes with an erection if you take it. So I think people have fear of that, and it's not how it works. So that's number one. And number two, there's actually no real data that they cause something called priapism, which people are very scared of. So priapism is a painful erection that doesn't go down, right? And unfortunately, it has to say on the warning label that if they have an erection that lasts longer than 4 hours, talk to your doctor. So one of the other main things I do is prescribe injectable medicines for erectile dysfunction. That you're probably really going to be going to a men's health specialist or a urologist to do that. It's probably less so going to happen in the primary care setting. Those medications are medications that can cause priapism, so the erection that won't go down, and they are going to work regardless of interest in sex. So those are the medications where I say, if you inject this and start working on your income taxes, you are still going to have an erection. So you want to use them judiciously, but they can be extraordinarily effective when the pills are not working. So I am a big fan of them, and they can be used extremely safely. You just need to have them prescribed by somebody who knows what they're doing. So that's that. And then there's a lot of other options, right? So there's surgery, there's penile prosthesis. So that's basically like an inner tube for the erection that is FDA approved. It's actually one of the first treatments for erectile dysfunction. You can find a urologist who does it, I'm sure. And it is covered by a number of insurance plans. And then there's what we call more of the regenerative therapies. So the idea of like, how can we improve the tissue health directly? So there's some data that in men with moderate erectile dysfunction using a low intensity shockwave device can improve erections. So that's where you're going into an office for like a series of 6 sessions and they're putting this shockwave. It's non-invasive and it can cause tissue regeneration. Less excellent data, but there is some data showing improvements if you use something called platelet-rich plasma. Again, that's not necessarily prime time. And then more experimental things are treatments like stem cell therapies. But those in the US should be in the context of a clinical trial.
I imagine that for a partner who is experiencing this along with the man who may have erectile dysfunction, this can also be, in a lot of ways, psychologically concerning for them as well. And so I'm curious about what that looks like in practice for you. Are you seeing couples coming in together? How do you counsel someone to talk to their partner about their erectile dysfunction, especially if it is impacting the relationship, impacting the self esteem of their partner?
I love it when couples come to the office together because then they learn about all of this together. And I think it takes a tremendous load off relationships. There is very few other areas of health where a relationship partner can take the outcome so personally, right? If your husband broke his leg and wasn't able to walk without crutches, you wouldn't take it personally. I can just say an extreme example. I've seen situations where somebody comes with their partner into my office for erectile dysfunction that happened at the time of prostate cancer surgery. So we know this is a very, very physical thing, right? It is very common that somebody can have injury to the nerves that go to the penis at the time of their prostate cancer surgery. There are many people with prostate cancer surgery where that doesn't happen, but it can happen. So if somebody goes and has prostate cancer surgery and they have a sudden onset of erectile dysfunction after that, and they come in with their spouse or their partner, and the partner breaks down in tears in my office and says they don't love me anymore, they won't have sex with me, and I'm like, again, this is why the education and the discussions are so important, and this is why this is a domain of healthcare. Because when I sit down and explain to them, this is the anatomy, this is the nerves that may have been affected by this surgery, it has absolutely nothing to do with you. And I know he looks at you and tells you that, but you still have this fear. You need to hear it from somebody else, right? You need to hear it from somebody else. I'm so glad you came along to this appointment, and I'm so glad you were vulnerable and you expressed the way you felt about this, because I have a tremendous role that I can do in helping them with their relationship, right? And I'm not a therapist, I'm not a relationship counselor, but me providing that medical information can take a tremendous burden off of people navigating these concerns.
I'd love to, in our last few minutes together, just hand it over to you for any final messages you have for anyone listening who's struggling or is part of a couple, a relationship where the partner is struggling with erectile dysfunction. What would be your advice for navigating this experience together?
I think number one, be open about it. If you say, hey, I've noticed that I'm having trouble with my erections and it's not you, right? Like, mention that, be open about it. Please seek out a trusted healthcare provider. That would be amazing. And involve your spouse in it, right? These are all important tools. I'd say also, and one of the core themes that come up in my care of patients is people wanting so desperately to have a good erection because they have not learned or they've lost the ability to see other ways of intimacy. And keeping that in mind is also important. And what do I mean by that, right? I always say to patients, like, when you were a teenager, before you ever had sex for the first time, you caressed each other and you hugged each other and you kissed for a long time, and you were excited about that. And while you journey through this process, keeping in mind what the true definition of intimacy is and using that to reinvigorate your intimacy with your partner is important. Like, of course I want to help you get your erection. That said, I have had patients that chose to not pursue any treatment, and they're having the best sex life of their entire life because they were able to focus on their partner's pleasure. They were able to do more erotic touch. They were able to do mutual masturbation, right? And so they reframed that. And I think providing that reframing of what this means, like the loss of the erection is not the loss of intimacy, can really be fundamental.
Beautifully said. And I want to thank you so much for your time. This has been such important information. You really helped to lay it out step by step for us. So, really, really appreciate the conversation.
Thank you so much for having me.
I'd like to share my three key takeaways from our discussion. First, erectile dysfunction is not just a sexual health issue. It's often your body's first warning sign of potential cardiovascular disease, diabetes, or high blood pressure. That's why it's so important to bring this topic up with your healthcare provider. It's not only a quality of life issue, it's also an indicator of overall health. Second, there are treatment options available, probably many more than you realize. Don't let fear, stigma, or misinformation prevent you from discussing these options with your healthcare provider. And finally, erectile dysfunction does not have to mean a loss of intimacy. It's important to bring your partner into the conversation, explore what intimacy means beyond penetration, and work with a trusted clinician. A certified sex therapist can also help open doors that may feel completely closed right now. Erectile dysfunction, does not have to mean the end of a fulfilling, connected sex life. You're not alone in this, and help is available. To find out more information about Dr. Winter, how to address erectile dysfunction, and other information about sexual health, please make sure to check out our show notes. Thank you so much for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.